We're going to move on to our first deep dive panel on health. And so I'm going to hand you over to William Thompson. He's the founder of Scotland's largest economics festival and podcast, Scotonomics. I'll pass on to William to introduce you to the rest of the panel. Thanks so much.
Good morning, everyone. How are we all doing? We're going to delve really as deep as we can in the hour that we've got into the challenges of the NHS in England, but obviously we'll touch a little bit on Scotland as well. Now, what I really wanted to do was to start kind of framing austerity before we get into the details of the NHS. Now, we're going to concentrate, I'm sure, on what I call fiscal austerity. And this is the desire to reduce day-to-day spending on services like the NHS to reduce the government debt. And as you'll have heard over the weekend, the desire to shrink the government debt by reducing services ensures that this can only be met by shrinking our net financial wealth. Now, on top of fiscal austerity, there's two other types of austerity, and we often don't consider or touch on these. And this is industrial and monetary austerity. And these are really important contexts for the conversation. Now, industrial austerity is structural. Our institutions are created and moulded to ensure low wages, high unemployment and deindustrialisation. By design, this leads to higher profits, offshoring of environmental harm, precarious contracts and hundreds of thousands of bullshit jobs, which, as you probably know, is a technical term. Now, I'm sure we're going to address this when we talk about low pay and conditions for many NHS staff. Now, finally, we've got monetary austerity. And we won't cover this in the conversation, but this is what's really important for the context. Now, monetary austerity generally means high interest rates. Now, this issue is magnified when interest is paid on reserves held on reserve balance accounts of the Bank of England. Monetary austerity ensures that interest-bearing bonds, which are often inflation-linked, it's really good when you're wealthy and you can link your borrowing to inflation. Very difficult for anyone else to do that, but not for the super wealthy. And this represents a significant injection of purchasing power into the economy. So I mentioned it yesterday when the question to the panel, but do you know how significant this injection is over a year? It's £160 billion. 160 billion has been spent in the last year of government spending on interest on bonds. Do you want to know what the NHS budget is? 188 billion a year. So we're almost spending as much on interest to the wealthy as we are on the National Health Service. Jaideep, I'm going to ask you what you could do with an extra 160 billion for the NHS. But this is really important because over the weekend, we've discussed that this is a choice. The government are choosing to spend money in this way and not on the NHS. And I think that's absolutely crucial as we have these conversations about funding the NHS. So consider the debate and the discussions around the waste and unsustainability of the NHS spending. Money that literally improves well-being and saves lives. And compare that to the level of understanding and awareness of that 160 billion that's paid on interest. Where's the outrage? Where are the calls for privatisation of this? The think tanks analysing every single pound that's spent. I think it's incredible that we spend so much time analysing how we spend money in things like the NHS and nothing on this 160 billion on government on interest on government bonds. So that's really important. It's a huge sum, and we would argue it's completely unnecessary. 160 billion of spending completely unnecessary in our economy. Now, the government could perhaps direct 100 billion a year to the NHS without increasing the debt if it decided to switch off interest on new government debt and paid that instead to the NHS. How does 100 billion sound? Yeah. But it chooses not to do this. Now, the other bit of context I wanted to give you is a bit local, well, it's national. If an English-trained doctor graduates now, they're expected to leave with £80,000 debt. If they'd graduated in Scotland, they would have had a much better time to start with, right? But their debt will be less than half that. Less than half for a new doctor. Since devolution, the Scottish Government has spent close to 10% more on health spending than the English Government every year. 10% more. And they choose to do that. A newly qualified nurse in Scotland earns around £3,000 more than a nurse starting her job today in Bristol. So far be it from me to kind of like rouse the English, right? But if I was you, I'd be thinking, this is absolutely disgraceful. But these are the choices the government can make. And in Scotland, the government is making these decisions. And it's not just on health. We don't have a concept of welfare in Scotland. We have the concept of social security. And the government in Scotland spends £272 per person more than the English government. £272 per person more. And that's simply because it chooses to do that. So when we're framing this austerity, I think it's really important to see where the money goes, and that's the choice, and what your government decides not to do. And the crucial factor is that the English government is the government that creates the currency. The Scottish government doesn't create anything, doesn't create the currency, but it decides to spend that differently from the English government. So I think the least that we should be demanding, that you should be demanding of your politicians, is that they spend as much as the Scottish government does per person, and they treat their staff as well as they're treated in Scotland. And I think that should be the absolute low level of what you need to demand from your politicians, because the evidence is overwhelming. If a country just north can do it, there's absolutely no reason that the English government can't do it. So it is a choice. Austerity across the economy, across society is a choice. And it's a choice that we don't fund and resource our NHS properly. Okay, so let's get into the details of how we change that, because there's two people with a plan. That's what I thought. We've got two people on the panel with a plan. Jaideep? Jaideep, do you just want to briefly introduce yourself, and then we'll get stuck into the questions?
Thank you. Thanks, and thanks for those opening words. So, is it not working? Oh, it's a bit closer. Sorry. Thank you. Thanks. So, my name's Jaideep Pandit. I am a professor of anaesthesia at the University of Oxford. I'm a clinical director of operating theatres there, so have a management, I'd say junior management role, not in the wider health service. But I'm also interested in, I've done research in, I have a doctorate in, and an MBA in health economics, and with a particular interest in how operating theatres, surgical operations are funded. And a few years ago, I was delighted enough to discover MMT as a potential solution, and have written some articles on that, which colleagues have kindly taken an interest in. So I'm going to be seeking to weave in some of those concepts as potential solutions to the challenges that have just been laid out. Thanks.
Hi everyone, I'm Emma Hughes. I'm from a patient-led organisation called Just Treatment, and we campaign for the end of profit-making and corporate control over our health systems. And by patient-led, we mean that all our campaigns are led by patients who have direct experiences of the health injustices that we are fighting on. So yeah, I should say I'm not an economist, I'm an organiser by trade, so coming at that with that lens. I also have to apologise, I'm also a single parent, and given the price of childcare, I unfortunately haven't been able to be here for the rest of the conference for that reason. But yeah, really excited to be here for a couple of hours, and yeah, really enjoyed getting my head into MMT a little bit, and yeah, sharing a conversation with you today.
Thank you to you both. Emma, so an easy one, and we're talking like kind of 2 or 3 minutes for an answer, but how does austerity manifest itself in the provision of health services for patients in the UK?
Yeah, thanks. This is an easy one and a slightly strange one to answer, because I imagine every single person here who has interacted with the NHS, particularly if you've interacted with the NHS over many years, will know exactly what austerity means for the NHS. There is no doubt that our NHS is crumbling. It is failing patients day in and day out in many ways, again and again. And we all have a very real, felt sense of this. I want to begin by talking about 3 patients, people who organise with Just Treatment, who share their stories regularly as a way of trying to highlight what is happening to our NHS. So I want to begin by talking about Samina Rahman. On Christmas Eve 2020, Samina was gathering in Birmingham with her family, her 2 grown-up daughters, and her husband, Iqbal. Iqbal was the last to arrive. He'd been out buying sweets for the family, sweets that they always enjoyed over Christmas. When he arrived, he looked incredibly unwell and complained of feeling very unwell. Samina works as a speech and language therapist in the NHS, and she immediately identified that Iqbal was probably suffering from a heart attack. Her older daughter, Sana, rang 999 immediately. Samina stayed with Iqbal. They waited 40 minutes while Iqbal's condition got worse and worse. They rang back. They were told an ambulance was coming. Again, Iqbal's conditioning was getting worse. He was asking where help was, and Samina had nothing to say. They rung back another 15 minutes later. Still no ambulance. After an hour and 20 minutes, an ambulance arrived. It was too late. Iqbal had died. The paramedics worked on Iqbal, but they couldn't resuscitate him. If that ambulance had arrived on time, Iqbal may well still be alive today. The next story I want to share is Mai. Mai works as an organizer with Just Treatment. Mai was sectioned when they were just 14 after a suicide attempt. They spent years in psychiatric care, eventually getting out, thanks to a very tenacious mother, their own courage, and some amazing staff. They then relied on community care for the next 9 years. As that community care was stripped away, they hit crisis point again and ended up being sectioned. They then spent the next 3 years moving between privately run facilities that the NHS were outsourcing inpatient beds to and NHS facilities. At either place, they received nothing that you could really call treatment. Instead, they were dosed up on benzos and sedated for most of the time. Eventually, Mai's family and friends had got together and crowdfunded to pay for Mai to receive treatment in a private facility. Ironically, it was one of the same hospitals where there had also been an NHS patient and had not received any decent treatment. Mai is now rebuilding their life, but they are left with deep trauma, psychological scars, and also long-lasting physical impacts from their time in institutions. And finally, I want to talk about Maggie. Maggie got a kidney infection. She rung up for an ambulance and was told to go take herself into A&E. In A&E, she got worse and worse as she was left overnight. Eventually, by the morning, she had persistent vomiting. When she was seen, she was then told there wasn't a urology department at that hospital and was sent to another A&E. By the time she arrived at that other A&E, she had sepsis. She was extremely ill and had to be operated on straight away. Maggie talks really powerfully about how the NHS nearly cost her life, but then saved her life. After the operation, she was left with damage to her kidneys and needed reconstructive surgery. She was told she had to have that surgery straight away, but the NHS couldn't give her a time as to when she would have that operation. She ended up paying £13,000 out of her small pension fund to pay for that operation because she was too scared to wait and risk further damage to her kidney. These are 3 very different stories, but they point to the state of our NHS and the impact of year after year of underfunding. And we hear these stories time and time again at Just Treatment, whether it's people not getting pain relief because there aren't staff to administer it, whether it's people fighting to get cancer diagnoses that then come too late, or just not getting dentistry. We all know the impact of underfunding on our NHS. In 2010, the coalition government inherited a world-class NHS. It was one that they proceeded to deliberately strip funding from because of the austerity agenda. This world-class NHS was created by decent investment. Now, I'm no fan of the Blair government, but one thing they did do was invest in the NHS. They committed to a 5% real terms increase every year in NHS investment, and that increased to 7% in later years. We're now at a point where we're lagging behind the European average by 40 billion. The British Medical Association estimate that there is a 423 billion shortfall since 2009. And this has left us with a situation of a dangerously overstretched NHS that is failing patients again and again.
And as I said at the start, the context is just so important, and I think we really do need to think about the individuals when we're talking about a service as large as the NHS. So, Dr. Pandit, how does austerity, kind of, and you've loosely defined it as cost-cutting in your paper. Can you explain how this cost-cutting in the NHS unnecessarily constrains capacity and quality of health service? And then we'll kind of return to the impact on staff a little bit later. But how does it impact the treatment that, from the stories that Emma's given us?
Yeah, really important question. And, just as a preamble, what Emma's just said is the focus of, all our activities as doctors. And it's ultimately the patients, who are bearing the brunt of this. The question's directed to me as a clinician as to how it constrains me, my teams, but actually it constrains the patients much more, as you've heard, and they're bearing the brunt. So everything that we're doing and trying to do is with that in mind. These are such shocking and saddening stories, so I'm really sorry and touched to hear those. So the question is how, to get back to the sort of dry areas of economics, how does this affect us and what is it doing to us? And in order to answer that question, that sort of, the funding structures, it's probably important to put up that slide. Is that possible? Can you project that slide? And I prepared this as a lecture and I realized then it was a panel, but this is a simplified version of the NHS funding system, okay? Now, don't worry about the numbers, but just stand back and look at how incredibly complex it is. Now, I'm not going to take you through it step by step as I might have done in a full sort of hour-long lecture. But right at the top, you've got the funding source, which I think you've got it. I can't quite twist to see, but it's government or parliament or whatever. And then through this web of organizations, all designed to adjust and control and balance and cost control, right at the end, right at the bottom, and in fact below the bottom, you've got people like myself as the clinical directors in charge of individual departments, and then my colleagues working, in the operating theatres as I do as well, and then of course the patients bearing the brunt of that. So in order to understand, that very simple question you've asked, what is the cost balance? In order to answer that question, we really need to unravel all that, and that's a big research project itself. So it's not a linear question to ask. It's not as if there's just one step between the funder and the person spending the money or the department spending the money. There's all that to contend with. It works, I'm going to summarize because we want to move on. It works in two ways. One is that the overall amount that we receive in any department, and this applies to any department across any hospital, and any hospital will say that, is less than the demands, okay? And that leaves us with a choice. And businesses who are faced with similar choices, they have three levers, broadly speaking, leaving aside innovation and investment for infrastructure and building, which are long-term things. So the three levers. This is what standard economics tells us. Correct me if I'm wrong, in economists. One is price control. Well, we can't control prices. We can't just change the price of surgery like Coca-Cola can change the price of cans, or iPhones can change the price of iPhones. We can't do that. The second is volume control. That is, they can decide how much to produce, or we can't say that to patients, please don't come in for a year. And the third is expenditure. And that's the only lever we have. But what does expenditure mean in the NHS? Well, it means doing less work. We don't have pointless expenditure. I mean, sure, there are efficiency savings and cost savings and looking for cheaper items of equipment, but they're really the tip of the iceberg. Ultimately, it relates directly to volumes of work. So a lot of the stories we've just heard from Emma actually relate to capacity and the ability to do the volumes of work. That relates to the timings and the time delays and so on. It's around capacity. And I'll leave you with a statistic. So what does this method that we've got produce in reality? And I've just written a paper. I sent that paper in press to William and colleagues. Every operation done, this is new research. In fact, it's not directly by my team. It's by one of my former students who continued the research, and I've written the editorial to cover this paper. On average, every operation done by the NHS loses the hospital £950. Okay? So I'm just going to repeat that just in case you misheard it. We lose £950, or you, the taxpayer, loses £950 for every operation done. That's the basis of the deficit. If there's a complication of surgery, in other words, it's a bad operation done badly with bad outcomes, you lose less, £850. The tempting solution to the NHS funding crisis is to do really bad surgery. Okay. But, I mean, that's weird. No one's going to conclude that. But my point is, that's what this system has produced, those numbers. It's not anyone being able to control it at the front line. It's the system behind us that's achieved that. So it's a long-winded way of answering your question, but that illustrates the challenge we're facing.
Thank you. Emma said that the NHS was a world-class organisation up until 2010, and then things changed. Is that your perception as someone who's in the NHS?
It's like watching a child grow up. You know, suddenly they're grown, and it's very difficult at the moment in time to know exactly where you are. It's certainly true, and the statistics bear it out, that the Blair-Brown era was one of investment, and the economic statistics bear that out. And it's certainly true that austerity was a real, belt squeezer. I mean, that was the intention. And of course, COVID didn't help. So it's difficult to say we're in a better place than that for all those reasons. Of course, there are mitigations. There's enormous hard work from colleagues. There's innovations and technology that have helped, and things that we've learned that also mitigate and make it better. So notwithstanding that, on the bald economic side, I think you guys have the numbers already to really substantiate what you've said.
Thank you. So, Emma, you're aware of the research that was carried out by Glasgow University that suggested that there was 300,000 premature deaths attributed to austerity between 2010 and 2015. 300,000, so almost double the deaths compared to COVID. And when I heard that figure, I thought, where is the public inquiry into that period? It's just been completely written off, but 300,000 people died prematurely for that period, and we've just left it and not looked at it. And what's even worse is that we're just about to do it again. And I think calling for a public inquiry, and I think that's what our politicians, our opposition politicians should do, is a public inquiry into that period of austerity. But Emma, I wanted to ask you, that's a huge and a shocking figure, but does that adequately sum up the damage that was done or has been done since that austerity period that started in 2010?
Yeah, it's a really interesting question. I mean, I agree, it's a totally shocking figure. And I think the other moment that always makes me stop when I hear it is that life expectancy in the UK has now started to fall. I always just think that's such a shocking indictment of austerity, and why there isn't more discussion and focus on that, I just do not understand. But yeah, as your question, I think, is pointing to, it actually doesn't do justice to all the impacts of fiscal austerity. And first of all, I mean, in the health system, as I think I've outlined, it's it's a system that is crumbling and is on its knees. And this affects, almost every area of care that you can think of. So you're talking about life-saving care, you're talking about preventative care, you're talking about routine care, and you're also talking about, things that go well beyond just the ability to live, but also, how we live. We're talking about dentistry. I remember my mum used to go to the doctor to get her ear syringed regularly. Can you imagine that happening now? People getting skin tag removes. So many areas of healthcare we are having to pay for now. And what this is eroding is the idea of the public health system. And of course, in its place, more and more corporations and private companies are being brought in instead. And this is worse for patients, but it's also worse for democracy. These companies are completely unaccountable. You only have to look at what's happening with data, with Palantir, a company which has ties with surveillance, and the Israeli military being brought in to run the federated data platform, making huge money off this very, very valuable data set that the NHS provides with no accountability, no transparency. And when patients go to doctors now, they're expected to trust doctors with this very sensitive information that then is being given to these unaccountable companies. So yeah, I do think we are eroding the idea of the public health system, and we are moving towards a two-tier health system. And obviously it goes beyond health. It's everywhere. It's swimming pools, it's libraries, I'm sure you've been talking about here, it's the welfare state. We are increasingly addressed as consumers rather than citizens. And I think the impact on that as individuals and how we understand ourselves and how we understand society should really not be underestimated. At Just Treatment, we also have this campaign called Mad Youth Organise, which is working with young people who are directly affected by the youth mental health crisis. They have collectively written a manifesto which talks about the impacts of austerity and the impacts of corporation on young people's mental health, making the conditions in which young people live unbearable, precarious, shit jobs, the climate crisis, unaffordable rents. These are the structural things that are driving the youth mental health crisis. So yeah, austerity is taking away our ability to live, but it's also taking away our ability to live well in, really, really profound ways.
Thank you very much. We've already got a two-tier health service, Scotland and then England. Prescriptions are free in Scotland, by the way. I know they cost you a tenner down here. But this harks back to this understanding that the money is not a problem, and that's what the MMT lens gives you. But the concern would be around real resources. So, Jaideep, I'm going to give you 100 billion more next year, okay? What do you do with that money? And what is the constraints that you have alongside not having the funding?
Well, I would turn it on its head. We don't have resource constraints, actually. Okay, that's the reality. It is said that we have a shortage of workforce. That is not true. Okay, we do not have a shortage of doctors or nurses per se. Okay, that simply is false. What we do have is a shortage of jobs that we're offering people who are qualified. Okay, that is true. And that is somehow framed as a shortage, which I've never understood that. I mean, it is a shortage if you create that, obviously, because you're saying we can't fill, don't have enough people to do the work. That is certainly true. But the second thing I'd say about the funding is the first thing to do with any injection of funding is to look at the way it's structured. That diagram that you saw earlier, that really has to change. And that austerity lens, or that orthodox money theory lens, really has to change to enable every pound of that 100 billion that you are offering me to actually reach the patient and do something productive. With a clunky system, it's inevitable that, like an old machine that's generating heat and the heat is lost, and the machine isn't doing what it's supposed to do, dig the hole or move you along the road, it's just wasted as heat. And although the complexity was designed almost in an evolutionary sense, bit by bit, by accretion, to try and inject efficiencies back in the system. As you saw from my stark example of funding of elective surgery, it's working against itself, and parts of the system do work against each other. So to solve the problems that Emma told in her patient stories, you think, oh, well, look, it's obvious what to do, and you try and do it, and you find actually it's had the reverse effect, or some other part of the system counteracts that. So the only way to use that £100 billion properly is to have an overhaul of the system as a whole, so it's efficient. And just to complete the answer, there is a way out, and it's linked to something in medicine that's well known. It's called value-based healthcare, and it's looking at, and I think one of the previous speakers said it. I think the keynote speaker said it about what's the economy for, and you get down to basics, what's healthcare for, is to look for value in outcomes. So don't just look at the number of operations that we're doing, the number of knee replacements, or the number of patients, but try and introduce metrics, which in the literature, research literature, do exist, to ascertain what are the value outcomes out of the treatments we're offering, and then design a system that incentivizes and rewards those value outcomes and disincentivizes complications, for example, which clearly the example given shows that this is not working in that sense. It's a non-value. I don't know what the reverse, what the opposite of the word value is, but that's what the system we've got is. So it is possible to link a value-based healthcare structure at the front end, on the front line, with an MMT approach to organizing the funding streams. And then you have a common sense, rational system that's doing what it's supposed to do.
Well, I'd like to open up to the audience if there's any questions for our panel. The gentleman just at the front, Sheridan, and then the lady over on the left of the stripe shirt. Just put your hands up again, sir. Yeah, there you go.
Thank you. Interesting stuff, isn't it? That's a really simplified structure up there, I think. It hides a lot of complexity in there. The last 15 years or so, we've seen a much more complicated structure evolve with private corporations, with all of the administrative overheads of managing a system where you have a commissioner and provider, all right? In the early days of the NHS, up until 1990, you had a simplified structure of hierarchy and regional distribution of the use of the resources, and properly funded. Never as much as you wanted, but properly funded. So it's brilliant to hear you talk about we need to look at not just at the money, but at the actual structure of the NHS. And if you don't go back to one which is accountable properly and responsible properly and simple, it will continue to be expensive. A nationalised industry properly run before 1990 took about 4 or 5% in administration. Now it's incalculable. They don't know how much, 30, 40%. That's a lot of money to go on non-clinical services. So yeah, I agree. And I just want to say thank you for that, because that was going to be my question, is who will look at the structure and how? It's not just about the money. Having said that, how do we get the money in to pay for the structure and for the people who've lost their purchasing power in the last 15 years? Right?
Great. No, thank you. I mean, great questions. And of course, the history of it, which clearly you're familiar with, is that back then, people thought that somehow that was an inefficient system. And how wrong they were, the things they put in to make it more efficient, as you've expertly observed, have made it worse. And now we're trying to dig ourselves out of the hole. I'm afraid it's beyond me to, what I don't have. Yes, it was a simplified slide. It's much more complicated than that in reality. What I don't have, and it's beyond my ken to do so, is to say, hey, here's the slide we should have. And that is part of the problem, that nobody has in their back pocket a sort of instant answer as to what the system should be. But I agree, if we are going to sit around the table, or people are, they should look for simplification in this, definitely.
Thank you very much. Another question here.
The problem really is that the whole of the NHS has been reorganised, and that reorganisation is split it up into 42 separate funding bodies. The NHS, using Professor Alison Pollock's statement, is that the NHS has been abolished, and all we have now is a logo called the NHS. All these bodies are designed basically to hand over a public service to the private sector. That's what we're faced with. And it isn't money, because they've used money in order to achieve this reorganization. And the only answer is reinstatement of the NHS. That's the sole. And the point about it is that what I find insane, and before all these changes took place, the NHS was regarded as the finest system in the whole world. And we went to the bottom of the table throughout international, to the American system, and they've introduced what they call HMOs, because that's basically what we have now, these 42 bodies. The American system, which is the worst in the world, and it is, the American system is double that of the NHS, and to go from the top of the table to the bottom to seek advice is madness. And like I say, the only solution is reinstatement. There's no other solution. And the other thing about it is people put their faith in the Labour Party, and I used to be a Labour Party member, but they put their faith in the Labour Party, but the Labour Party is part of this deconstruction and dismantling of the NHS, and it is being dismantled. It's being salami sliced to the point where the NHS, the NHS as we know it will just not exist anymore.
Thank you very much.
Yeah, I mean, that's a very accurate summary of the history, completely. And what it does at the moment is, of course, you see the Secretaries of State of Health, and I don't distinguish the governments here at all, because they've all bought into that same principle where we are today. They're not changing that in the way that many of us would like to see. They write the check, they make the announcement, they say we are investing more and more as a headline thing. But then that structure dissipates that headline sum into something that actually vanishes and becomes a negative quantity right at the bottom end. And that's what that complexity has created. So you are right about the perverse outcomes as a result of the fragmentation.
Could I add one question from online, just very quickly?
Yep.
Yes, this is related to, could you comment on Wes Streeting's idea of using spare capacity in the private sector and the touted reintroduction of PFIs? Thanks.
Yeah, of course, yeah.
Yeah, so I was horrified to hear about the reintroduction of PFIs, paying for these neighbourhood health centres across the UK. And of course, I'm sure you're all well aware of the disaster of PFIs for the NHS, the privatisation of profit and then the socialisation of the risks and the costs and what that has meant, saddling the NHS with eye-watering costs and debts. It's an absolute disaster. And again, in terms of privatisation, and I mean, Wes Streeting, you mentioned the Labour Party, Wes Streeting is paid £10,000 a month by private healthcare companies. I think it's clear in whose interests he is working. Yeah, he is continuing the privatisation agenda, which has been so disastrous for the NHS. Private, it's the state, it's the NHS who train staff. And then it is the private companies who poach that staff, draining resources from the NHS. At Just Treatment, we hear time and time again from patients who have basically denied access to these private healthcare companies that the NHS is outsourcing to because their conditions are too complicated. So if you are too old, if you are deemed too overweight, then you will be referred back to the NHS. The NHS cherry pick the treatments, the patients that they can make profit off, and of course it is the NHS that is left having to deal with the more complicated procedures, the more complicated patients. It has been a disaster for the NHS, and moving away from privatisation is a key part of what we need to improving patient outcomes. And democracy is a huge part of this as well. Wes Streeting pays a lot of lip service to democracy, but in actual fact, what he is offering is increasing a reliance on corporations, particularly tech corporations. He is using tech as a kind of silver bullet to the problems of the NHS, which unfortunately it just isn't going to be. And in the process is handing more and more control over to these corporations. And at Just Treatment, we're really concerned about what that means for patient voice. Where are patient voices represented meaningfully in the NHS? And as we've spoken about, these very convoluted, complex structures mean that there is just decreasing accountability, and patient voice is not being heard.
So thanks. I think that was a great question. I'm going to answer it on two levels, really just to explain some of the economics and some of the reasons why that situation has happened. On a superficial level, yes, there is, inverted commas, capacity in the private sector. So instinctively, as a doctor and even as a patient, you might think, well, great, why shouldn't we use that? Because there's capacity there. So on that superficial level, that equation seems to add up. But if we take a step back and ask, well, why is that capacity there and where does it come from? Well, it comes from the same staff who spend 80% of their time working in the NHS. So then you say, well, hang on, why can they not just be paid more to work in the NHS? And why do we have to bring in the private sector with all the problems that Emma articulated? And the fundamental reason is, again, the system working against itself. And I'll give you an example. It's going to be the consultants who obviously predominantly work in the private, but it's also nursing staff doing their shifts. Austerity, George Osborne, and I wrote a paper on this, and I predicted that this would happen in that paper, and in our specialty, in our area, it's a well-known piece. Changed the doctors' pensions. Without boring you, the end result of that was that if a consultant worked the extra hours in the NHS, they would lose all that extra money. They would be working for nothing. That does not apply if they walk across the road and work in the private hospital. They get to keep the money that they've earned through working. That's the way the system has been set up by the government itself. And that has not changed. There's been some tinkering, but it has not changed. So the capacity in the private sector exists because of government policies. Now, they may not have dictated it, they may not have wanted it that way, but that is the predictable result, which I predict, and somebody like me could predict it all those years ago, and it has happened. It's obviously true. And that's then linked to separate pots of money within the system, back to that complexity. Imagine, and I'm simplifying it, a pot of money for NHS extra work that's limited. There's a separate pot for the private sector work, believe it or not. And the two can't be mixed. You can't say we'll take from that for that. They're separate. And so you either use it or lose it. Again, it's simplifying it, but that's the drivers that are creating that capacity. So yes, on a superficial level, if somebody said to me, yeah, look, of course we're going to have to use it, but taking a step back and reflecting, somebody has to ask, why does it exist in the first place?
That's really important, I think, to get to that level of detail. When we spoke yesterday, you spoke about the international market for healthcare, and I just wonder if you could touch on that for us. And a doctor or a nurse in the UK, what are their options, and how do we need to look at this in an international perspective?
Yeah, great question again. And the world has gone global, and with the internet and WhatsApp and Twitter and so on, people know what's happening elsewhere much more quickly. I think we had a colleague from the United States who asked the question. There's been post-COVID, post-pandemic boom in the healthcare industry, understandably, because those waiting lists, just like demand for iPhones, fuel need for healthcare, and prices have gone up, wages have gone up. I shudder I haven't looked at the latest GDP figures, but American healthcare was consuming a huge proportion of American GDP. That's not a good thing. It's more so. American salaries have gone up. Average salaries for a nurse, $250,000. I won't even mention my colleagues in anaesthesia, what they're getting. They're eye-watering figures. The problem they're having as a result is things like burnout and overwork, whereas we're complaining about our meager salaries, they're complaining about overwork. And elsewhere in the world, because of that more private, the market it works. And the way the market's working when demand is high is, of course, what you see increased prices, increased wages. That's just the way it works. And are people going away? I looked up after our preparatory conversation. It's difficult to find the exact figures, but yes, it has gone up. There's always an attrition of medical students, about 10% through leaving medical school or failing exams or whatever. You can squeeze that down through better courses and training, but it's about that figure. The figure leaving in training, which is the critical period, including for periods of 1 to 3 years, which is absence from the NHS, let alone permanently, is 20%. So we're losing 30% of our staff even before they're consultants, and then consultants are moving too. The only barriers are language barriers and sometimes extra exams that they have to do, but they're overcoming those. So this is not something that we've factored in as the cost of austerity. We haven't factored that in. And the data are really difficult to find. They are obtainable, and somebody should do a project to get to the bottom of this. Because we've invested in those people, notwithstanding student fees, student loans, I should call them officially, but you know what I mean. Notwithstanding that, they are making those choices. And the alternative, I don't know the data for Scotland, but what Scotland is achieved, which is where we were before, which is create a community that's locked into the vision of the NHS. So you get education for free. You understand the system. It's clear what it is, and it's a supportive system that's directed to patient care in the way that it used to be. That's changed because they're now coming out monetized with that debt, and they're looking for solutions to meet that debt, and they're making inevitable choices.
We've got about 10 minutes left.
Exactly. Yeah, 10 more minutes.
We'll take a question, but I've got a question for Stephen, if you can just ponder this. I just wonder how we can frame the MMT lens for both our panelists with the problems that they've got. Could I ask the question? So I'm going to give you a few minutes to think about that. So it's not, I don't feel too bad asking you that. But how can we, so when, I want both of you to, when you leave, to think this MMT lens is helpful and this will allow me to say or do something. And I'm putting that challenge on Stephen. Question?
Yeah, there's a couple of things really. I mean, if you look at how complicated this is for doctors, can you imagine what it's like for us? Trying to navigate a child's mental health crisis when you've got this part saying, well, you've got to go, we'll look after you for this number of weeks. Then we've got to decide with these people whether you're going to go here or here. Then they're going to say, well, you've got to try here first. If that's no good, then we'll have to come back here. And all the time your child is suffering, and things are so complicated now. I believe they have actual navigators to help you through the system, which is somebody else that shouldn't really need to be paid for, or this person could be doing something more useful. And for me, going back to MMT, this PFI nonsense, this is what MMT strips away. We don't need the private sector to come in and help us. We also don't need private hospitals to be charities, while NHS hospitals have to pay rates. The whole system is just not only complicated but ridiculous, and it does the exact opposite of what it's supposed to be doing. So for me, MMT is the key to the start of this, and then going back to the NHS as it properly was, we'll do the rest.
Question over the end there. That was a really good question, and Stephen, that might have got you out of jail there with summarising the usefulness of the MMT lens. But I do want to come to you to finish. Yes.
Oh, I'm here, over here.
Oh, hello.
This is more of just an observation and a comment. I am American. My background is in health care administration. I worked for a major hospital. I know a lot about private enterprise in medicine. And I used to be in meetings with my boss who used to talk about medical procedures that we did as products. And I want to say that it's capital. I mean, it's the money. It's the huge amounts of money flowing into the health services. And it's just wrong. There's no place, just no place for private enterprise in a public healthcare system. It is a disaster. I worked for many, it's a little, traumatic for me sometimes, because when I came over here, that's what kind of woke me up as and it was a whole different ball game. And that's all I wanted to say.
Yeah, I'll just say thanks for that. And you're right, it is obviously, completely at odds with, what should be a public healthcare system, that, the main concern should be public health outcomes. And I'll just hook onto this just to very quickly mention, because they haven't been mentioned so far, the pharmaceutical industry, which, we pay billions and billions to, who are set up with a very, very well-defined rule playbook on how you extract as much money as possible from public health systems, resulting in the denial of access to medicines for millions and millions of patients, and a model of medicine which is based on drugs which you can make profit of, really underutilizing things like public prescribing.
You're absolutely right, and we haven't quite got there in the NHS, but, this is a but, the paper I referred to on costing and pricing and the loss from each operation, there is behind the scenes in that complex network of model, the funding model, a system whereby each operation is assigned a price. That does exist. It's public knowledge, you can look it up. You can imagine a step further if things got really extreme in the way we don't want them to get to, where hospitals will say, actually, this operation is no longer worth doing. I mean, that is true in the harsh economic sense already, but they're not taking that step further, saying we're not going to do it. But you can see the dangers of going down that orthodox money theory line of pricing everything. It's arbitrary, but nevertheless, it has a price tag on it. Because you can see the consequences of that if, in OMT terms, you're then asked to balance the budget, because that's the logical decision to make. So I think your input has been very important to warn us of going down that line, which is looming if we're not extra careful.
Thank you. I think we'll probably got time for one more question.
Thanks. I just kind of wanted to bring it back, as you said, to the kind of MMT prescription. Oh, that's a pun, isn't it? Sorry. For the health system, I think it's a really useful archetypal example. It's our biggest, most obvious area of public expenditure. We doubled spending in the previous Labour era for various reasons broadly. Perhaps we need to double it again. Let's say it's 100 billion we need to spend, right, to bring the health, notwithstanding all the other changes you guys have been describing. As a non-MMT economist, a non-economist, what are we actually saying needs to happen? Are we saying that the state creates this 100 billion, maybe it's 25 billion a year, ramping up through this parliament, the Bank of England buys that, or we spend it into the economy, we don't issue bonds, we don't go after the 5.7 trillion in asset wealth and property wealth that we have in the country, which is kind of the orthodox progressive solution. I'm just trying to understand what are we actually saying needs to happen? Because I think if we can be clear on that, we can start to use people like Zach Polanski to campaign for this. But we're all sort of saying, the MMT solution, and it's not actually clear to me what we're saying, what we're asking for. And I'd really love the MMT economists in the room to articulate that as clearly as possible so we can kind of get behind it, basically.
Okay, thank you. Well, very briefly, the first thing I would say is we need to change the fiscal rules. And that the fiscal rules are designed to reduce day-to-day spending, which you can include the NHS in that. So that's the first thing, is that Zach should be campaigning for a removal of fiscal rules, and that instantly it changes the rules of the game to do that. Have we got 5 minutes? Yeah, it's fine. Okay, there was a very, very quick question, and then I'll let Stephen summarise if that's okay. But just a lady there in the middle, Sharon. Is that okay?
Hi, it was just to clarify, when Pandit mentioned value-based healthcare, could you expand that a bit? How does that contrast with values-based healthcare?
The second of those may be around the ethical aspects. The first of those is around the end result of surgery, of interventions. For example, I'll give you a really crude example. Something like a hip replacement is generally a good thing to do because it gets people mobile and walking, and they don't get, pressure sores and deep vein thrombosis and all sorts of things, and they can be productive if they're at working age. But a hip replacement in someone wheelchair-bound with multiple sclerosis, who might have a bad hip but no pain, is of no value at all. Yes, it fulfills the criteria because it looks bad on the X-ray, but it's not going to get them walking. This is a very, very crude example. That's not to say disabled people shouldn't have surgery. It's just an extreme example just to illustrate the sort of metrics. And there's a lot of literature around refining what value means in every context.
No, sorry.
We could link the two then. The answer is yes. We could say, let's look at value-based and also link in the values-based for the well-being of the public.
Values-based is a given. I mean, I hope we're all practicing ethically, and yeah.
Brilliant, thank you. Okay, Stephen.
Okay, well, I see modern monetary theory as an umbrella, not just for health policy, but for the discussion of progressive policy generally in the UK. I see it as empowering to be able to say that the fiscal rules, which are in place at the moment, and their forerunners that have been in place at least since the Cameron government, and in a less severe sense even before that, make absolutely no sense at all. At the moment, it is possible for there to be a significant increase in public spending on the health system and investments in the health system without that spending being inflationary, in my view. What do I think that the UK government should be doing at the moment? I think that the UK government should be running a larger fiscal deficit than they are currently. So I do not think that significant additional expenditure on the health service necessarily needs additional taxes in order to drain funds from the economy in order for you to be living within your productive capacity right now. There is no reason not to fund investments in the health service to improve the provision of health services in this country, at least, as William was saying, to shift the system in England, at least to where they are in Scotland. And there's no reason to be scared about increasing the share of gross domestic product being invested in health. Indeed, that is a sensible thing to do in a rich country with an aging population. It's exactly what should be happening. So experts like those on our panel should be involved, and the community more widely should be involved in discussing the type of health system that people want to exist in the UK. And it's then a matter of looking at whether you have the real resources to do that quickly, including the people and the skills and the technology. And you have to look at the institutions, and you have to look at how the system is structured at the moment. And a plan needs to be in place, and it needs somebody with courage and with the sort of charisma that I think people like Zach Polanski actually have to make the case to
Well, let's go back to the 1940s, shall we? To introduce a national health service in the United Kingdom.
Thank you very much. Yeah, just 1 second. Yeah, Emma is an MMT newbie, aren't you? Emma? And I think we had a 5-minute introduction and overview to MMT on the phone, which is the most challenging thing I think I've ever had to do in my life. But Emma, could you just very briefly tell us if you think that this MMT lens is useful in the work that you can do and that you've been doing now?
Yeah, thanks. And thanks for the invite to engage with MMT. It's been really interesting, and thanks for being up for that challenge, Stephen. That was, really useful as well. I do think, I really like the word empowering. I do think there is lots about, as an organizer, I'm interested in how can I use this to organize around. And I do think there is lots in the MMT analysis that is empowering. In particular, has been said already, it really blows the old lie that there isn't enough money, that you're competing for money out of the water. I think it is really powerful from that perspective. I guess and showing that the constraint isn't money, it's political will. I guess the question that I have as an organizer is looking at the momentum at the moment, which is around taxation, increased taxation. And I think there are useful things about that demand beyond just, moving money. I think, when we are taking money away from billionaires, from corporations, essentially what we are doing is taking power away from them. They get power from inequality. So I think it's an important demand to be making, and it's also one that is, gaining in traction, gaining momentum. Now, I don't think MMT and tax demands are at all necessarily mutually exclusive as far as I understand, but it's how do you frame MMT to really talk into that debate and to talk to where the debate is at. And part of what makes taxation powerful for me as an organizer is that it names the villain. It names billionaires, it names corporations. So I think the challenge I would have for you is how are you going to frame MMT so it, because I'm working with patients with various experiences. I could see using MMT in a weekend workshop where we're delving into it together and we're really understanding it. Where I struggle at the moment is when I'm working with those leaders to do media appearances and, they've got a soundbite and people go on and call for more taxation and they're laughed out of the room. How do we, of course, there's always a job of work to do to, push the Overton window, to push common sense. And those arguments aren't going to land in the media right now. But what's the communication? What's the framing that we need to be doing to make that land, basically?
That's a challenge for us all, but I want to give Jaideep the last words.
Yeah, just a very quick question, and it was on the slide posed as a question, and it's to help my own understanding of MMT and development of that understanding. But I use the example of say, and it only applies to some proportion of the population, not everyone in the example you'll see. But let's say a worker breaks his leg, and the NHS fixes his leg, and we count that as a cost to the NHS and part of the fiscal deficits referred to. And if we step back, we can say, well, the worker breaks his leg, the NHS fixes his leg, the worker then is able to work and earn the country money. Is there no way of accounting for that intervention as an investment and as a return on investment? So the NHS is actually earning a profit and has never been in deficit, ever. I look to the economists and the accountants in the room.
That's another interesting challenge. Do you want to finish, or do you want to...
I don't know how to answer that question, but I do to the previous one, which is, this is part of what's empowering. Yes, we should be taxing wealthy people more highly. It's a vital tool to reduce their command over resources, to limit their political power, and to reverse, and I feel very strongly about this, reversing the criminal increase in inequality, which has happened in the UK, hasn't happened in every other country over the last 50 years. It needs to be reversed. But the investments that need to be made in the National Health Service are not hostage to you winning that argument on taxation. You can do it anyway. The two things need to happen together, But I think it's particularly empowering that your millionaires and billionaires in this country do not fund your health service. That's not the way your monetary system works. And in some of their cases where they are engaged in economic activities which are not of positive benefit to the community, and which activities which damage the natural environment. When they say, if you tax us more highly, we'll leave the country, you should offer to drive them to the airport.
I think that's a great note to end it on, yeah.
Well, thank you very much. A really engaging session, and thank you to our panelists. Thank you.